Alrighty. A lot of coughing that's going to be on this one. It's going to be great. All right. So let's get started. We have a lot to cover in an hour and 45 minutes, unfortunately. So we'll start off with the spondyloarthropathies. Can anybody tell me some basic features of the 4 spondyloarthropathies? Anyone? Anyone? I'm getting shaking of heads. I mean, just give me... Well, that's one specific one, right? So there's 4 different spondyloarthropathies, and as you can see here in the headlines, ankylosing spondylitis is the one that you guys commonly know the most about. It's the one that has the highest association with the HLA-B27. Psoriatic arthritis is another spondyloarthropathy. Reactive arthritis, formerly known as Reiter's syndrome, and then as well as IBD-associated arthritis. So all 4 of these things have certain features in common. So does anybody want to make a guess as some of the features that they have in common? SI joint involvement. Okay, good. I like to hear that. So sacroiliitis is one of the common things that you'll see across the board here. What else? Eye stuff, not necessarily in all 4. Definitely in reactive, definitely in ankylosing spondylitis. Huh? So that's again going to be seen a bit more commonly with ankylosing spondylitis. So there's a couple. So it's HLA-B27 positivity, right? Ankylosing spondylitis having the highest association. It's 90% of the time. The other ones being about 50-50. Hence why it's not actually diagnostic. But I just want you guys to start thinking of these features, because when you start seeing an illness script with these features, you should start thinking, okay, this is going to be a spondyloarthropathy that I need to be considering. So if they say something about HLA-B27 positivity, if they tell you something about sacroiliitis, consider it. If they tell you about enthesitis, can anybody tell me what enthesitis is? So inflammation of the insertion of tendons, right? So the Achilles is like a really common site that you'll see enthesitis in of itself. So enthesitis is another thing that you'll see commonly run through all of these things, essentially. And then another one that you can see sometimes is dactylitis. So your quote-unquote sausage finger. So if they start talking to you about any of those types of things, start considering that, okay? And then obviously they're going to tell you that rheumatoid factor is negative, because these used to be called the seronegative spondyloarthropathies, and that means because the rheumatoid factor is not necessarily associated with it highly. There's a few that you can get a false positive, but it's not like something that you see commonly associated with them. All right, so starting with ankylosing spondylitis, because this is the one that you guys clearly probably know the best since medical school and everything else. I already had somebody shout out bamboo spine, which is very classic in regards to ankylosing spondylitis. So SI joint is going to be the main common sort of arthritic feature that you see with ankylosing spondylitis. It's low back pain. It's very classically described as a young male, usually, so somebody in their 20s that has a lot of low back pain, and that they notice that the pain gets better with exercises as well as hot showers. So that's going to be very common classic features that you're going to see for somebody with ankylosing spondylitis. So this one is going to also have large joint, shoulder, and hip pain. It's usually symmetric. The stiffness, as I already said, gets better with use, more commonly seen in men. There are a lot of extra-articular manifestations of ankylosing spondylitis, and a lot of them starts with A's. You can see here, it's like listed out A's, so kind of think about the A's with ankylosing spondylitis. So anterior uveitis, this is probably, I think it actually is, not probably, it is the most common extra-articular manifestation of ankylosing spondylitis that can actually be the presenting symptom. So this is one of the weird ones, that they can actually present with anterior uveitis before even necessarily the back pain. Aphthous ulcers, aortic insufficiency, that was actually a question that I have seen before, where they didn't want me to know the diagnosis, because they gave me a beautiful picture of bamboo spine, and it wasn't, what is the diagnosis? It was, what cardiac anomaly could they have, or something like, what valve issue or replacement or something along those lines. I can't remember the exact wording. But it was basically you had to recognize the bamboo spine, recognize this is ankylosing spondylitis, and then be like, oh, okay, there's aortic insufficiency. This patient's going to need a valve replacement. Okay, so that's, they're not going to be kind, like as this is not going to be step 2. They're going to give you a bamboo spine and you're just expected to name it, okay? Coronary artery disease, as you guys know, just expect CAD and anything in rheumatology. If you have some sort of autoimmune disorder, you're going to also have coronary artery disease, okay? Apical fibrosis with restrictive lung disease, this one's really kind of also a key thing. I mean, they get very pronounced apical fibrosis, and then they oftentimes have a very restrictive spine. Once they, like, the ligaments actually completely fuse together, you don't have a lot of movement, so it also can cause a restrictive lung disease associated with that. I actually had an amazing patient with one of my panel patients at the VA, had AS, and he had all of this. So it was really like a great way to get it cemented. And he unfortunately also had a really bad kyphosis and COPD underlying, so his lungs were horrific, basically. But he also had his valve already replaced by the time I took care of him. All right, so you guys know the bamboo spine, so it's calcification, anterior longitudinal ligament. They may want to try to trick you just by the descriptions of stuff by making you think dish. Remember, that's going to be kind of actually more right-sided. It's not necessarily going to be the entire thing, and it's not going to be the bilateral where you get that perfect bamboo spine with dish. Sacroiliitis is, again, one of the key hallmark features of all of these things. This one's going to be more likely bilateral. It's going to be symmetric. If you have a high index of suspicion and the x-rays are negative, you go for an MRI. That's another common mix-up question that I see all the time. So you have a very high index of suspicion, you get the basic x-rays, they're negative, MRI. So MRI the SI joints, because that's what's really going to help you make the diagnosis, okay? And I already mentioned the HLA-B27. This is the one that has the highest association, but again, not diagnostic. So treatment for this is another thing that I've seen in a lot of mix-up questions, et cetera, is how do you treat ankylosing spondylitis? So you can actually start off fairly conservative with just doing exercise and NSAIDs, okay? And if after, weeks, a month goes by and they're not having a response, you can actually potentially switch the NSAID and switch the dosing and see if that helps. Then after that, if that does not help, we get aggressive and go straight to TNF-alpha inhibitor. So there's none of those other DMARDs in between. You go straight to a TNF. And it's because of the extra-articular manifestations can be so devastating that we're not going to mess around, okay? But if it works with exercise and NSAIDs, then you're usually pretty good. So it just kind of depends on the case. All right, any questions about ankylosing spondylitis?
Just clinically, how long would you give them a trial of exercise and NSAIDs?
It's a couple months only. Mm-hmm. If there's no response. I've seen a couple of variable things, so it's like 1 month, 2 months, 3 months, but it's not going to be years that you're going to be doing it, and they're not well controlled.
Have you seen questions where they make you choose like the treatment based on imaging findings or anything? Okay.
No, it's always going to start off with exercise and NSAIDs in general. I mean, I imagine if they actually already have these extra-articular manifestations, which is pretty rare. I've never seen anything like that where somebody has had these symptoms for years and now are just now presenting. I've never seen that type of question base. That might be where in real life people would probably be more aggressive and give a TNF-alpha at that point, but I've never seen that in a question base. It's always been, I think they like the idea that you can start off with exercise and NSAIDs. And then it's a pretty quick jump. It's like that escalated quickly, straight to TNFs afterwards. Psoriatic arthritis. So what do you guys know about psoriatic arthritis? Pencil in a cup. Okay, I like that. That's fantastic. So that's a good x-ray finding is pencil in a cup. What else?
Nail pitting?
Nail pitting. So that's a huge one, right? So it's not like 1 or 2 pits. I've had so many medical students, residents be like, I have pitting. And it's like 2. And it's like, you don't have pitting. You're not going to get psoriatic arthritis. Calm down. It's extensive pitting that you're going to see. And it can get even bad that you can get actually like lysis of the nail bed. It could be that bad of pitting. Okay, so yes, so nail pitting, those are great. Those are great things to have in your head associated with psoriatic arthritis. And this is the one that dactylitis, the sausage finger, is also really common with, is psoriatic arthritis. So you see commonly in the dip joint, enthesitis is another thing common. Again, of course, the SI joint, the dactylitis. This one could be of a large joint, more asymmetric, oligoarticular arthritis. It's not going to necessarily be symmetric like you would see with AS. But it also can be symmetric. So it could very much mimic that of rheumatoid arthritis. The difference is the dip is involved. Okay, so if they're going to try to trick you up on that, if dip obviously involved, you know immediately it's not rheumatoid arthritis. So also you have uveitis, psoriasis of course, but you don't need to have the psoriasis rash to have psoriatic arthritis. So it's also one of those other things. We talked about nail pitting, coronary artery disease, whichever. So we already talked about the deformities that you can classically see with the pencil and cup deformities. plus or minus 50-50 with the HLA-B27. This is one where you could have a false positive rheumatoid factor associated with it, making it all the more confusing that you can get the symmetric joint involvement, but again, DIP involvement. Short term, you could try treating with NSAIDs. Steroids and hydroxychloroquine can make skin worse. Remember with psoriasis, you try to avoid systemic steroids as much as possible because it can cause a rebound of worsening of the rash. So we try to avoid systemic steroids at all possible causes in psoriasis. So long-term methotrexate is actually a great 2-for-1. So it'll actually treat the arthritis as well as the skin rash. And then, of course, the TNF-alpha inhibitors will also do the same, right? It'll also treat the skin as well as the arthritis in of itself. And you can also use your interleukin inhibitors too as well with plus or minus methotrexate. Alrighty. Reactive arthritis. What causes reactive arthritis? Yeah, so infectious agents. So which are the common infectious agents that we think about that can lead to a reactive arthritis? So GI, good. And then chlamydia. Yes, excellent. So chlamydia. Please do not think that this is disseminated gonococcus. Two very, very different entities, okay? So chlamydia is the one that causes reactive arthritis. And then your GI is like Shigella, things along those lines, okay? Oftentimes it's very difficult to test for those infections because they are usually self-limiting. Chlamydia is kind of the one that you can do a urine amplification, like nucleic acid amplification test to test for the chlamydia if you have that concern. All right, so how does this actually also present? So here you can get, of course, the sacroiliitis. That's our classic hallmark thing with these, right? You have asymmetric knee and ankle pain. You also can have enthesitis, Achilles tendonitis, plantar fasciitis. You can get uveitis associated with this one. Keratoderma blennoragicum, do you guys know what that is? There is a picture on here, so right, this right down here is the keratoderma blennoragicum. It could be on the palms and it could be on the soles. Okay, so that's keratoderma blennoragicum. How about circinate balanitis? So that's a little bit different. So that's a urethritis that's associated with it. So you can get a urethritis. This is an actual rash. So it's this. So this is circinate balanitis. Exactly. Circinate balanitis.
What's it called?
Circinate balanitis.
Do you expect like a foot rash and the penile rash to improve with treatment?
So it's all usually self-limiting in general. So oftentimes it'll just get better on its own. However, occasionally we do have to treat. The treatment is mostly actually if you try to treat for the actual infectious agent, it's difficult, right? Because especially all of these, the Salmonella, Shigella, Campania, Yersinia, those are all self-limiting. And in general, by the time you actually present with a reactive arthritis, those GI symptoms have actually resolved. So it's difficult to actually treat for the infectious agent. Chlamydia is the one where you can test for with, again, the nucleic acid amplification test of the urine and treat the chlamydia if you actually do find it. So that's something that you could do there and try to treat that. Other than that, you're really focusing at the symptoms in of itself. So you can do NSAIDs, of course. You could do steroid injections, since this is going to be more of an illegal articular arthritis, that you could potentially do steroid injections if the NSAIDs aren't working. Usually the antibiotic therapy is not going to be particularly effective. For chronic, because this can, in some patients, actually become something chronic or can last over 6 months up to a couple of years, that's when you can consider methotrexate or sulfasalazine in those patients. Those are rare, but you can see that sometimes where it can be a chronic, slightly debilitating arthritis that you can see associated with it. So then there's IBD associated arthritis. So I was just rounding with somebody's team, Agatstain, it was your team, right? And we talked about the two different arthritides associated with IBD. So one is a spondyloarthropathy, and then there's one that's not a spondyloarthropathy. So who would like to tell me about the arthritides associated with IBD? So one is associated with disease flares, the other one is not. Can somebody tell me? So there's a spondyloarthropathy, axial one, and then there's a peripheral arthritis. So which one's associated with disease flares? No, it's peripheral. Peripheral is. And so that one doesn't exactly fit here in the spondyloarthropathy necessarily, the peripheral one. So the peripheral one is going to be your larger joints, ankles, knees, wrists, etc. And oftentimes people will know if they have IBD that they're getting a flare because they'll start to have those symptoms first even. And it's tricky, right, with IBD, because what can we not use to treat arthritis and IBD? NSAIDs, right? We don't like to use NSAIDs in IBD. It can worsen flares. It can cause a flare. So we try not to actually use NSAIDs. So that's a little bit tricky here. The axial one, again, is the sacroiliitis, right? So that's going to, again, be one of our spondyloarthropathies that we can see associated with it. Now, uveitis, of course, can be seen with just IBD in general, not necessarily, of course, the actual spondyloarthropathy in of itself, but it'd be a little bit difficult to discern between the two, in all honesty. So the sacroiliitis has nothing to do with the disease flares in of itself. They can have it chronically just in general, okay? So the extra, like, kind of articular manifestations is obviously this is seen with your Crohn's or UC. It happens in about 20 to 30% of patients with IBD. Nephrolithiasis is actually more from the IBD, right, in of itself. So again, plus or minus HLA-B27, the peripheral joints we already talked about correlates to the IBD disease activity. So short term, we avoid NSAIDs, so here we can use steroids instead. Long term, methotrexate, sulfasalazine. The sulfasalazine will help to slightly treat the joints and the bowel. The methotrexate is really going to be mostly for the joints. And then, of course, the anti-TNFs will treat both, too, as well. Okay? All right, any questions? No? So we have some pictures here. Sorry, I thought I was going to be able to scroll down. So pictures, what do you guys think this is here? Right, that's your bamboo spine. That's classic, like step 1 or 2 even, right? Step 2 probably picture. So here, what do we see here? The pencil in a cup, very good. Go away, this thingy.
I think you can scroll down to use the bar on the side, maybe.
Wait, how do I do it? What?
The bar on the side. It's a little like incrementally.
Huh?
Just like a bottom area.
Ah, it went away. Okay. Alrighty. What's the, if I like move it, is it gonna come back again though? What's that? So what is this here? Yeah, see, it comes back again. Mother bitches. Yeah, I don't know. Okay, so this is dactylitis. Okay, we'll ignore here. Uveitis is what's being covered up, right? So yeah, so we got uveitis being covered up there. There it is. You guys can see the uveitis. How about with the pelvic? What do you think they're trying to get at there? Sacroiliitis. Very good. The nail, clearly, some pitting. And then we kind of already talked about the cratoderma blenneragicum. That's the soles. And then the penile lesion is the circonite balanitis. Yeah.
The oil drop sign, is that with psoriatic arthritis?
Not familiar with the oil drop sign. Look it up and get back to us.
It is. Another study does talk about that associated with psoriatic arthritis.
So what exactly is it though? What's the oil drop sign?
It looks like there's an oil drop on
Yeah.
the nail.
On the nail. Oh, interesting. Okay. Oil drop sign, discoloration of the nail. Sorry, I haven't personally seen that one before. Pitting is the classic one for me because this one actually has a pretty high association as the pitting. I don't know what the oil drop signs association is. Alrighty. Moving on. So rheumatoid arthritis. Who wants to tell me what they know about RA?
Morning sickness.
Morning stiffness. Yes. How long does the morning stiffness typically last for?
More than an hour.
More than an hour. And they will not be tricky. They're not going to tell you like 55 minutes. And they're going to be like, oh. No, it'll be like, they have 90 minutes of morning stiffness. It'll be something very, very obvious. So morning stiffness is great. It helps you to differentiate between that and osteoarthritis, right? Because osteoarthritis, usually, it's quickly, right? If they have morning stiffness, it's like 10, 15 minutes. That's it. It's not going to be greater than an hour. And it's something called the gelling effect, right? So even if patients sit for a long period of time, so if they go on like an international flight and they don't move for 8 hours, they get that morning stiffness all over again. Okay, so if you're just immobile for a while, it's the gelling effect. All right, tell me about the arthritis. Symmetric in general, right? Small joints, good, exactly. So think about all the different small joints that you could see it with specifically, good. Which joints are not involved? Not the dip. What else is not involved at all? And this is how you know patients you call BS on them when they talk about their RA flaring.
Low back pain.
When they talk about low back pain, right? If they talk about just back pain in general, you're just like, it's my RA. No, it's not. So you have something else going on in your back? It's not rheumatoid arthritis. What joint in the back is actually involved? Technically the back, quote unquote back. Specifically, right. So like your occipital atlantal joint, right? So that's the only one that we worry about that actually has RA involvement in of itself. So nothing else in the actual spine is going to have any involvement of RA. So good. So remember, not the dip, not the spine, most commonly smaller joints in general, symmetric, very good. Okay. We can get some pretty interesting deformities that you can see on exam too as well. So how would you guys describe those deformities? Swan neck, good, exactly. So those are just basically kind of like the opposite, right? So like this is like your swan neck one, right? And then the boutonnieres is like that. The big thing about these is, can you reduce these deformities? No, right? Or you're gonna break their bones. So don't try to reduce them. Okay, so like that would be bad. That would be bad. They're not reducible, and then of course you can get the ulnar deviation. And so here's like a beautiful picture of the ulnar deviation that you can see here. Alrighty. Other things associated is Baker cysts can be associated with RA, and then of course the rheumatoid nodules also seen associated with that. Rheumatoid nodules are one of those poor prognostic indicators. So if somebody has the nodules, it usually means they're going to have a bit more severe of a course or harder to treat course. What do you guys know about rheumatoid nodules and methotrexate? Alrighty. Okay, so this is another classic mix-up question that I've seen numerous times, where somebody comes in, they have RA, they have rheumatoid nodules, you put them on methotrexate, they get worse. Exactly, the nodules get worse. And that's not the question that they ask you. They don't say, what happens to the nodules? They tell you that the nodules get worse. And then they say, what do you do with the methotrexate? You continue it. Excellent. So you just be like, I'm sorry, I know these things are unsightly, but we're actually controlling your disease. It just is what it is. You have to deal with the fact that you have these ugly nodules, unfortunately. But that I've seen in every mix-up for the past 5 mix-ups, okay? All right, rheumatoid factor, of course, it's 70% sensitive, so you do have 30% false negatives associated with it. A high titer will also tell you another poor prognostic indicator that it's going to likely have more severe disease. CCP is very specific and sensitive to that of rheumatoid arthritis, okay? X-rays, I've seen again in a lot of mix-up them describing X-ray findings, and you guys being able to sort of understand what those X-ray findings are seen with which disease, okay, of the joints. So if they start talking about periarticular osteopenia and marginal joint erosions, you think RA specifically, okay? We'll talk about OA later and what you kind of expect to see with OA specifically. So we already talked about the rheumatoid nodules on the skin. You could see pyoderma gangrenosum with it too as well. You can get a rheumatoid vasculitis. In the eye, the most common eye finding is actually this sounds really fancy, the keratoconjunctivitis sicca. That's dry eyes. Okay, so that's the most common eye involvement of RA is just dry eyes. So that's another kind of question that I see frequently too as well. But you can get worse ones too, episcleritis, scleritis, uveitis, keratitis, all those kind of itises in general. Well, if we get to it, there's a few questions that Dr. Aller has written about just the red eye in general, which are always good to review. My least favorite, but good to review. So pulmonary, you can get a pleuritis, exudative pleural effusions associated with RA. Do you guys know what you would find on the pleural effusion, like the glucose and the pH? Low. Low glucose, low pH. So if somebody has an effusion associated with RA and you tap it, check a glucose level, check a pH. If that's what your index of suspicion is that it's coming from the rheumatoid arthritis, and you expect to see a low pH and a low glucose associated with that. Alrighty. You can also get interstitial lung disease, cardiac, of course your CAD. You can develop a pericarditis. Felty syndrome, some team here is definitely taking care of a dude that we just had with Felty syndrome. So yes, Stephanie, you got to take care of him. Cameron was on HEMONC consults at the time. So you guys will never forget Felty syndrome. Yes. He had it for how long? Like 20 years, something ridiculous. Huge hepatosplenomegaly. We were giving him we were trying to give him Neupogen, and he was basically just gobbling up whatever neutrophils he made with his ginormous spleen that he had. It was not very effective, unfortunately. So he had a neutropenia. He had known RA, although his RA was actually quiescent at this time. So if you think splenomegaly, neutropenia, and RA, you should think Felty syndrome, okay? So how do we treat RA? Methotrexate is one of our best friends when it comes to rheumatoid arthritis. So we really started off at the onset of disease as you give them methotrexate. Other options are sulfasalazine, hydroxychloroquine. Leflunomide is kind of equivalent to that of methotrexate. So for whatever reasons they can't tolerate methotrexate, usually leflunomide is the next one that we're going to go to. Both methotrexate and leflunomide are crazy teratogenic though. So it's very difficult in your female population to try to use those medications. As you know, methotrexate is not just teratogenic, it's an abortic what's the right word for it? It'll actually obviously cause spontaneous abortion, hence why we use it as a treatment for tubal pregnancies. So don't use that in a pregnant woman, please. So biologics that oftentimes are used in conjunction with that of methotrexate are your TNF alphas. You can also sometimes use rituximab and then these other ABs and IBs, because I'm not going to try to pronounce it because I'm going to just destroy it. Steroids you use until your DMARDs kick in or anytime you have an acute flare. Okay? Any questions about RA? It's pretty classic, right?
Pretty straightforward.
Pretty straightforward in general. There's a few that I've seen with MixApp that is interesting. So somebody who you have a history of RA and you put them on one of your TNF alphas and now all of a sudden they have lupus-like symptoms. What do you think is the cause there? Drug-induced lupus, right. So like the first couple times I saw that question, I'm like, oh, is this going to be lupus, which is the legit name for like an overlap syndrome between rheumatoid arthritis and lupus. I am not kidding. And I want somebody to please name their dog Rupus because it's just amazing. But nobody has done it yet. But yes, that is the actual official name for overlap of rheumatoid arthritis and lupus is lupus. But no, so they're trying to do the timing of it, right? So this patient never had lupus-like symptoms before. 8 weeks ago, had just been started on a TNF alpha inhibitor. Now they have lupus-like symptoms, so think drug-induced lupus. I don't think we have all gotten comfortable with the idea of the fact that TNF alphas cause a drug-induced lupus. And the other thing that's tricky about those two as well is that the antibodies that you test for it, what antibodies come back positive for drug-induced lupus with a TNF alpha inhibitor? Not antihistone. ANA and anti-double-stranded DNA. So it makes it even trickier because it looks just like lupus, right? So, but it's again the timing of everything. So you stop the med, everything gets better, those antibodies will resolve. All right. Now, speaking of lupus, let's transition on over to lupus. So as you guys know, there's a much higher preponderance in females. It's more severe in certain patient populations, in particular African American, Chinese, and Hispanics, which I think that this is pretty easy for us to see here on the inpatient basis because the majority of our patients with lupus nephritis tend to fall into one of those three categories. Right? So inflammatory polyarthralgia is seen, small and large joints. This is, however, non-erosive, unlike your RA, right? So the type of joint pain that they get with lupus, when you do x-rays, you're not going to see the erosions associated with it. You can eventually develop osteonecrosis of the hip because, of course, the long-sitting steroids that these patients tend to be on. You guys know the SOAP brain MD. So you need 4 out of 11 of those criteria in order to diagnose somebody with lupus. Although I've had a lot of nephrologists argue if I biopsy your kidney and it shows lupus nephritis, we are done. Right? Like I don't need to have any other criteria, but in general they also will, right? Because if you have lupus nephritis, what antibody is going to be positive? So double-stranded DNA is going to be positive. Your ANA is going to be positive. So right there you already have involvement of the kidney. You have 2 different lab tests positive. So that's already 3 out of the 4 criteria. So you're likely going to have a 4th criteria. That's not going to be that difficult. The anemia associated with it, remember that this has to be not just like an anemia of chronic inflammation, right? You could see a pancytopenia. You could see a hemolytic anemia associated with it. All right, so ANA, is very, very sensitive, but not specific. Right? We all know that. That's why we don't just randomly, willy-nilly start ordering ANAs on people because it could be positive, mildly positive, and a whole slew of things that we don't know even why it's positive. So, but however, it's very sensitive. So if somebody has lupus and they have a negative ANA, you start kind of rethinking your differential a little bit. Now, it could happen up to 5% of the time, but you still would have to have a very convincing reasons to think that this patient has lupus, okay? Complement is decreased during a flare. We know that something we can use. Also, anti-double-stranded DNA is usually increased during a flare if that's something that they've already had positive before. So if you are looking for disease activity on the inpatient basis, it's appropriate that you can order those things to see. Although, of course, they sometimes take a while to come back. Other antibodies that can be seen associated with lupus is your anti-Rho and LA. Double-stranded DNA we already talked about. Anti-Smith, which is another one that could be a bit more specifically to lupus, is anti-Smith. And then anti-U1RNP, which is also seen with mixed connective tissue disease. So what are some of the findings that you guys see? So skin, there's a whole bunch of findings that we can see. So what are some of the rashes we see associated with lupus? The classic malar rash, so that has sparing of the nasolabial folds. And you have a lot of photosensitivity noted with it, so people will notice when they go out in their sun, the rashes tend to get worse. Then you can have your subacute cutaneous lupus as well. So that's going to be annular, erythematous with fine scales specifically. Discoid, scalp and face, think about that. The discoid thing, really keep in mind with discoid is it's scarring. So the discoid will scar, you get alopecia associated with it because of the scarring too as well, whereas the subacute cutaneous lupus doesn't scar. Oftentimes when somebody has also the cutaneous lupus, they typically don't have a lot of organ involvement associated with it. It's a little bit more of a milder form of the disease. They can get the joint pains and things along those lines, but not typically like a lupus nephritis or pericarditis or anything else along those lines that you would typically see. So good. Raynaud's phenomenon is also seen with lupus. Hematologically, it can cause a whole bunch of things, right? So you will see your autoimmune hemolytic anemia associated with it. So like your Evans syndrome, so patients who have ITP as well as the hemolytic anemia, lupus is oftentimes the driving force for that. So if you ever have somebody with Evans syndrome, you should really start asking questions to see if they potentially could have lupus. Anemia of chronic disease or really chronic inflammation is this. ITP we just talked about. And then, of course, you can get your pancytopenias. GI, you can get some dysmotility, reflux, painless oral ulcers seen with it. The aphthous ulcers, obviously, is really the big one. Remember that they're painless because that's, again, one of our criteria specifically. Pulmonary, you can get a known pleuritis, exudative pleural effusion, interstitial lung disease, diffuse alveolar hemorrhage. I've also seen that in real life. Acute pneumonitis. Shrinking lung syndrome is a very, very rare kind of Jeopardy type question, and it's exactly what it sounds like. They basically kind of lose volume of their actual lungs in of itself. Cardiovascular, pericarditis, myocarditis, a Libman-Sachs endocarditis. So that's your non-infectious endocarditis that you can see, which is associated with antiphospholipid antibody syndrome specifically. And then, of course, coronary artery disease. Renal, you guys know the nephritis. So you'll look for an active sediment on the actual, urinalysis. It's not going to be a bland urinalysis. You're going to see proteinuria. You could see hematuria. You see casts associated with it. You have to biopsy to figure out the subtype of the actual lupus nephritis. Neuropsych, you can see lupus cerebritis, which of course is an emergency. It's scary, and it can present with altered mental status, seizures. That's the psychosis, obviously, the altered mental status. All right, drug-induced lupus. So oftentimes drug-induced lupus will present as like basically a fever, an arthritis, and a rash. Antihistone positive, when you start thinking of those classic drugs that you guys all learned about, because the TNF-alphas were really just kind of coming out when you were in medical school, right? So all the other meds, your hydralazine, your procainamide, things along those lines, you kind of think associated with drug-induced lupus. Probably you've never seen anybody on methyl-dopa before. I don't know if you'll ever see anybody on methyl-dopa, maybe in your pregnant population potentially. Quinidine, minocycline, you sometimes see for acne patients, but keep in mind that the antibodies may be different depending on the drug. So if they're anti-TNFs, really look at your double-stranded DNA. Minocycline can actually cause an ANCA positivity. That's supposed to be INH, not IHN. That's a typo there. And then PTU as well. So a whole bunch of meds that can actually cause a drug-induced lupus. So really the stems, just think about the timing. They're going to tell you incidentally that they were started on a new medication. And at first when you're reading the question, you're like, why are you telling me this? And then you're like, okay, it's the timing. Stop the meds, see what happens. Neonatal lupus, this is something that we always have to be conscientious of, especially when it also comes to sort of counseling of a patient who wants to get pregnant, who has known lupus. You really want to know their anti-Rho positivity, because the anti-Rho is the antibody that's going to cause the increased risk for the actually crossing over the placenta and creating a congenital heart block. So that's commonly asked about in mixed-app too as well. All right, so treatments specifically. So if they have skin involvement, hydroxychloroquine, Plaquenil is kind of our classic one that we really want to go to. It also can treat some of the milder forms of arthritis. It'll also decrease that risk for congenital heart disease in patients who have that Rho positivity and are pregnant. So think Plaquenil in those regards. What's the big thing that you guys have to remember about Plaquenil? Eye exams, right? So they need a baseline eye exam, and usually every 6 months to a year they need recurrent eye exams because it can cause a retinopathy. If they're having an acute flare, obviously steroids is going to be our best friend in those regards. Lupus nephritis, the mainstay is really mycophenolate mofetil is going to be our mainstay. You may need cyclophosphamide first to induce the remission, but all the questions I've lately been seeing when they're asking about lupus nephritis, it's straight to mycophenolate mofetil. That's what they're going to ask. And then if anything is refractory, then you can use belimumab. Okay, that's lupus specifically drug there. All right, any questions about lupus?
What type of antibody treatment is that? Belimumab? I'm not familiar with that.
I just looked this up too the other day and I forgot because I'm pretty sure it's not a TNF alpha.
Page 34 says it's a B lymphocyte stimulator.
Is it B lymphocyte stimulator? That's what it is? Yeah.
The first drug in 50 years to be approved for lupus.
First drug in 50 years.
Yeah,
Look at that.
There were like all these drugs that other drugs are like off label or whatever. not
Right.
approved
Oh,
for
that's so
lupus.
funny, yeah.
And then that one was
Belimumab.
Now it's like, oh yeah, we finally have a lupus drug.
Yes. I'm like, I just knew it was not a TNF alpha. That's the only thing I knew specifically about it. All right. Sjogren's syndrome. What do you guys know about Sjogren's? Dry. So, right? Dry eyes, dry mouth. Exactly. What's that? You can get an RTA. Excellent. Yes. An RTA associated with Sjogren's. What else? Rowan law positivity. Good. You got to know the antibodies. Trust me. Antibodies, just have them at the tip of your tongue at all times. Antibodies. What else is associated with Sjogren's?
Do you have an increased risk for lymphoma?
Huge increased risk, like over 40 times that of the general population for lymphoma. And so that's why if they come in with like horrible parotiditis, not only do you treat with antibiotics like anybody else, you would actually have to go and biopsy it because there's that concern for lymphoma. Huge increased risk. And it's obviously a non-Hodgkin's lymphoma associated with it. Okay, good. So let's kind of dig a little bit deeper here. So you guys already know it's dry eyes. It can cause corneal damage, vision issues. The definitive testing is the Schirmer test, and that's like where they put like a little piece of paper next to the eye and see by capillary action how much like liquid is absorbed. I tried to order that one time and ophthalmology laughed and laughed at me and they were just like, we don't do that any longer. So I was like, okay. Anyway, that's fine. Dry mouth, the biggest issue with dry mouth is they get a lot of cavities associated with it. You need your saliva to protect your teeth. So we already talked Rowan law. You can occasionally see ENA positivity as well as rheumatoid factor. If you really, really need to know, the lip biopsy is the gold standard. And that was actually, so like, I don't know if you guys have the full Mix-Up 17 or 18, but they have those flashcards. And that was like one of the flashcards of this was like, okay, how do you definitively rule out or rule in Sjogren's? It's a lip biopsy, okay? As Cameron already mentioned, you can get a type 1 RTA associated with it, as well as interstitial nephritis. You can get an interstitial pneumonitis. They also can have a pretty profound arthralgia arthritis associated with Sjogren's, which I don't think is something I ever really always connected in my head until I met my first patient with Sjogren's, and that was a pretty profound one that they would have. They can get a neuropathy and mononeuritis multiplex. We talked about lymphoma. PBC is also associated, as well as cryoglobulinemia. So treatment, you can do artificial tears and saliva. We do have the cyclosporin eye drops, which is like, advertised to the general population, which makes no sense. For mild stuff, you could do NSAIDs, hydroxychloroquine, low-dose steroids. For very severe disease, you can do methotrexate, azathioprine, mofetil, and then cytoxan or cyclophosphamide, especially if you have the interstitial pneumonitis associated with it. So, any questions in Sjogren's? Yep. All right. Mixed connective tissue disease. So this is an overlap. So anytime I ever had a question about mixed connective tissue disease, the stems always basically start off where I'm like, oh, they have lupus. Oh, wait, no, maybe they actually have systemic. No, maybe they have a dermato or polymyositis. So if you start going into 3 different directions, and you take that step back and be like, okay, this is mixed connective tissue disease. Okay, so they're going to have a little bit of features of lupus, a little bit of features of systemic sclerosis, and a little bit of features of some sort of myositis associated with it. Okay. So the antibody, know the antibodies, know all your antibodies, anti-U1RNP. The titer, ANA titer should be high as well. So the features, right, you get the arthritis, myositis, you can treat with steroids, azathioprine, methotrexate. They also can get a Raynaud's, which is obviously going to be both a lupus and systemic sclerosis type feature. You can use calcium channel blockers. I mean, there's a tons that you can use for Raynaud's, right? You can use topical nitrates if it's bad enough too as well. You can also use sildenafil for Raynaud's phenomenon. Esophageal dysmotility, that's obviously a feature of systemic sclerosis. You really want to just give the PPI because they have so much reflux associated with it. Obviously, it's not going to do anything for the dysmotility in of itself. Interstitial lung disease, cyclophosphamide. And then pulmonary hypertension, your basic pulmonary hypertension medications, right? So your phosphodiesterase inhibitors, your anti-endothelium type medications, et cetera. And just say good luck in those regards. So mixed connective tissue. I've seen one question in mix-up on these, again, for numerous mix-ups now at this point. Just think about those three systems kind of overlapping, those three different diseases overlapping. These pictures, so this is, of course, your obviously ulnar deviation. The stupid bar keeps getting in the way. The other skin rash that's seen here, discoid, right, because it looks like it could be scarring. Your malar rash is the third one. And, of course, that last one is pretty extreme Raynaud's, right, pretty extreme when their fingertips are going white. All right, so systemic sclerosis or your scleroderma spectrum, right? Because it kind of is a little bit of a spectrum of things that we will see associated with systemic sclerosis. So we really are getting away from the term scleroderma in general. It really is systemic sclerosis. One thing that's not on here, another thing to consider is if you just have like one area, so like one patch of something that looks like skin thickening and something that you would see associated with systemic sclerosis, but it's not anywhere else and they don't have any other of the extra skin manifestations that you see with systemic sclerosis, that's morphea. Okay, so morphea, M-O-R-P-H-E-A. Morphea is just kind of an isolated patch, essentially, of what would look like systemic sclerosis without the actual systemic portion of it, okay? Yeah, morphea, M-O-R-P-H-E-A. So other than that, there's obviously some overlaps between diffuse versus limited too as well. So you can see sclerodactyly, Raynaud, digital infarction, dysphagia, lung disease, mucocutaneous telangiectasias, arthralgias, myalgias, and fatigue kind of across the spectrum of the board. So when we talk about diffuse systemic sclerosis, I'm going to talk about that first, okay? So how do you really, besides lab testing, because we'll get into lab testing in a second, and antibodies, but on physical description, how would you be able to differentiate between limited versus that of diffuse?
Like the areas involved?
Yes, so it's areas involved specifically, right? So if it starts proximally becoming involved, so proximal to the elbows, proximal to the knees, this is likely going to be diffuse. Okay, so that's like a little trick to think about. If it's distal, then you'll probably need antibodies to help differentiate, okay? So you get the chest, abdomen, arms, etc., that skin thickening that you're going to see. So proximal to the knees, proximal to the elbows, start thinking this is diffuse systemic sclerosis. So you get internal organ involvement, a bit more severe than that of limited as well. So it's systemic, it's diffuse that you worry about your scleroderma renal crises, right? That's somebody who's going to have diffuse, not somebody who is limited. Lung involvement, the lungs are involved differently between that of diffuse and that of limited as well. So we see interstitial lung disease with diffuse. Now, do keep in mind, if you have bad enough interstitial lung disease, you will develop pulmonary hypertension. But with the limited, you just see isolated pulmonary hypertension. You don't get the interstitial lung disease, okay? So interstitial lung disease, huge, huge thing that you see associated with diffuse. And then, of course, your renal crises as well. Antibodies, this one kind of spells it out for you, right? Because it's anti-SCL. So it's like starting to spell scleroderma. So that's nice, right? So anti-SCL70 is going to be your diffuse antibody to keep in mind. And, of course, ANA. Now, talking about the limited one, we already said it's going to be distal, right? We're not going to see the trunk being involved with limited in regards to the skin thickening. Crest falls underneath that of limited. So you guys tell me what CREST stands for, please. C? Is it up there? Okay, good. Calcinosis. Okay, good. So you guys can see this. Calcinosis, Raynaud phenomenon. I mean, you should not have to look at it, like this should be off the top of your head. All right, calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias, right? So that's your CREST in of itself. Internal organ involvement is generally rare, but again, I already mentioned you get the pulmonary hypertension, and the antibody is anti-centromere. So in the flashcards, for example, here they'll say antibody associated with pulmonary hypertension with systemic sclerosis. They don't even say diffuse versus limited. So you need to recognize that that's going to be anti-centromere because it's limited. So, or antibody associated with interstitial lung disease in systemic sclerosis. That's going to be diffuse, and that's anti-SCL70. Okay? So pulmonary hypertension, obviously you make the diagnosis like you would anything else. You could do with a screening echocardiogram, and then of course a right-sided heart cath. All right, now how do we treat? So for the whole everything systemic sclerosis, no treatment. You treat the individual symptoms as best as you can, and none of it's great, unfortunately. So Raynaud's, all the classic Raynaud's, avoid cold temperatures, don't smoke, you have your calcium channel blockers, your platelets, topical nitrates, sildenafil. If it's severe, you can actually do digital sympathectomy, surgical debridement. Sometimes you need amputation. So for dysphagia, you worry about micropulmonary aspiration that you can get. PPI, of course, is the big thing. You can try your motility agents, like Reglan. Sorry, I'm not going to be able to say the actual word today. And you guys all know the efficacy of that. Not great. Gastric vascular ectasia is something that's commonly seen with that. So so we talked about the telangiectasias, right, that you can see on the surface of the skin, same kind of concept, just in the lining of the stomach that you could see. It's called GAVE, it's like usually anteric vascular ectasia in of itself, causes kind of oozing of blood. It's a chronic loss of blood loss, so that can lead to an iron deficiency anemia that you can see in these patients. So they can try to do some lasering of various different things, but it's difficult to treat, in all honesty. Scleroderma renal crisis, we just had a very bizarre case of this in the ICU. I know that they presented, didn't really have anything else associated with it, except they had that one antibody positive that's not commonly tested on antibody. So how do they present, though? So if you're writing an illness script for somebody coming in with a renal crisis secondary to systemic sclerosis, how would you write that illness script?
Diffuse skin involvement, recurrent pulmonary edema, hypertension.
How do they present, though, to the hospital, right? So they'll give you that background information, because they oftentimes will not even tell you that they have a diagnosis. They will say they've had a long-standing history of skin thickening or something else along those lines. But how do they acutely present with renal crises? Hypertensive emergency, and what else? Renal failure, what else? Huh?
Bleeding.
Not necessarily bleeding, but something to do with the blood.
Clot.
Like a
MAHA. They have a hemolytic anemia. So that's kind of the classic illness script that they typically would say. So somebody who's coming in with hypertensive emergency, like out of nowhere, right? They may have been either no history of hypertension or well-controlled high blood pressure. Now they have hypertensive emergency. They have a MAHA associated with it and acute renal failure. That's when you're going to start thinking, okay, this is a scleroderma renal crisis. How do I treat? Captopril, right? High-dose ACE inhibitors. High-dose ACE inhibitors. Captopril being the one that's been studied the most, and that's why we use Captopril. All right, excellent. The interstitial lung disease, you can try throwing some cyclophosphamide on them. Good luck again with that. Pulmonary hypertension, your classic kind of pulmonary hypertension medications, and I say good luck with that as well. All right, so that's systemic sclerosis. Bummer of a disease completely, since there's really nothing that we can do to slow it down or stop it. All righty. Relapsing polychondritis. What do you guys know about relapsing polychondritis? So you think of your cartilage, right? So think cartilage in of itself. And that's why the ear is such a great example, because if you notice, the redness stops here. And why is that? There's no cartilage in your lobe, right? So that's why when somebody says, oh, my ears constantly get red and swollen, you have to, and if you think relapsing polychondritis is on your differential, you have to ask them, is it your whole ear? Or is it just the auricle of your ear? So that's what you really have to try to differentiate. What's the scary thing, though, about relapsing polychondritis? So tracheal, right? So so you have to make sure that you can protect the airway. Like, that's the scary thing about it, essentially. So yes, you can get a polyarthritis, ocular inflammation seen with it, so you can get a uveitis, conjunctivitis, cochlear involvement, respiratory tract. Of course, the tracheal larynx is the biggest, scariest thing. Going back to RA, I forgot to mention this in RA, I'm sorry. So they start saying that they have hoarseness of the voice. What are you worried about with RA? They could actually have maybe like a little bit of a stridor. So it's a cricoarytenoid arthritis that you can see with RA too as well. That's a kind of a rare thing, but it just showed up in one of my, I think it may have been the flashcards where I just saw the cricoarytenoid arthritis kind of coming back up with rheumatoid arthritis. Alrighty, so but with this, airway protection is going to be your big key thing. If it's just mild and just associated with the ear, you can do some low-dose prednisone. If it's actually involving your airway, you want to do high-dose steroids. It can also affect the aorta, so definitely want to do high-dose steroids there too as well, associated with it. I've also seen patients receive IVIG for a lot of relapses too as well. I don't think they're going to ask you that on your exam. I will, other than the classic like ear one, let me know if they actually tell you have any other relapsing polychondritis type questions on your exam. Behçet's. Who wants to tell me about Behçet's? Mouth and genitalia that are not HSV positive, right? So that's the first thing that we do when somebody comes in with oral and genital lesions that are ulcerating. We worry about, of course, HSV. You have to swab them, make sure it's not HSV before you start telling anyone that they have Behçet's syndrome, which is extraordinarily rare in of itself. What else, though, do you see with Behçet's? Pathergy. So that is pathognomonic, but it only happens in like 10 to 20% of the patients with Behçet's. So this is where oftentimes it'll be seen when somebody is like starting an IV on a patient and you have like a sterile pustule that will develop. So that's your classic pathergy type finding, and it's associated with Behçet's, but again, it's still rare in the actual patients. But if you have non-HSV related genital and oral mucosal ulcerations and pathergy, it's Behçet's, okay? But I've never seen this. This is one of those diagnoses, and I'm always just like, come on, and no. Because the problem is there's no antibody testing. There's no lab testing that you can do to actually verify that this is going to be it. So other things that you need to be concerned about is they get arterial inflammation, so they can develop aneurysms and stenosis, pulmonary artery aneurysms, thrombophlebitis. They can get the pan-uveitis. That's what I see a lot in illness scripts written as uveitis, associated also with the oral and genital ulcerations, erythema nodosum. They can get acneiform type lesions. They also can get a meningitis too as well. A meningoencephalitis is associated with Behçet's. So treatment, if it's just ulcers, you can do low-dose steroids and colchicine. Severe disease is high-dose steroids, azathioprine, and a TNF-alpha inhibitor. So, yet to see Behçet's. Adult onset Still's disease, what do you guys know about that? Fevers, really high ferritin. Rash, but what about the rash? How would you describe the rash? Besides salmon color, they sometimes use another word. Evanescent. Evanescent, yes. And what else about the rash? That's interesting. When do you see the rash? With the fevers, right, exactly. So you see the rash with the fevers. So the rash goes away with defervescence. So I think that's also kind of interesting about it. So you also get an arthralgia associated with it, right? So they get arthritis. They oftentimes will have a sore throat. They have a leukocytosis that is usually a neutrophil predominant leukocytosis. Splenomegaly can sometimes be seen too as well. And then a super duper high ferritin. So think about adult onset Still's disease in your FOU workup, right? Fever of unknown origin, or FUO, sorry, I can't say my letters correct. So fever of unknown origin type workup. Think about adult onset Still's. Check a ferritin, it's a good screening level. Although it's the Yamaguchi criteria that actually will help you differentiate. And I'm pretty sure ferritin is actually not on the Yamaguchi criteria. It has to do with lymphadenopathy, the leukocytosis, sore throat. There's major and minor criteria. You don't need to necessarily know that for the board's exam, but for real life, it's real quick and easy if you're considering it to look up the Yamaguchi criteria and go from there. They may ask you the name of the criteria, though. That's a possibility. So treatment, though, you can do high-dose NSAIDs, prednisone, and methotrexate. And then if it's severe enough, this is where you use your interleukin IL inhibitors. Okay, so that's the interesting thing about adult onset Still's. There are overlaps too as well, so sometimes you'll see it overlapping with lupus, which makes things interesting because the treatments, aside, like if it's severe, we don't really use our IL-1 inhibitors with lupus necessarily, but the prednisone and methotrexate could potentially overlap a little bit. All right, so that's our salmon-colored evanescent rash that you see there. Sarcoid. In the United States. So that actually has to do with the demographics of where you're at, right? So sarcoid is seen worldwide, and it's going to be different depending on where you're at worldwide of the demographic. But here in the U.S., yes, think of your African-American females as being somebody who's going to have a higher preponderance of seeing sarcoidosis. Excellent. Non-caseating granulomas, I mean, that goes back to medical school, right? Like when you start hearing non-caseating granulomas, what do you have to consider there? I mean, it can affect everything, right? That's the thing about sarcoidosis. It's one of those classic sort of mimickers, right? We throw it up on a lot of differentials, okay? So lungs is the most common, obviously. We think about pulmonary involvement with the lungs in of itself. It can cause a myopathy, it can cause lytic bone lesions, it can cause eye involvement, anywhere, right? Anywhere you can see those granulomas, essentially. Now, there are two other subsets of sarcoidosis that you should be aware of because they are tested on fairly frequently, Lofgren's being the number one. So who can tell me what Lofgren's syndrome is? Hyaluronopathy, ankle arthritis, and erythema nodosum. Excellent. And so the common mix-up question that I've seen with that is them saying somebody's coming in with an ankle arthritis and erythema nodosum. What's the next step? Chest x-ray. Chest x-ray. Chest x-ray. So then you'll see that. And that actually in of itself is a self-limited disease. It's a clinical diagnosis and it portends a fabulous prognosis. So you don't typically necessarily have to do anything. You could do supportive care in regards to some of the treatments there that's associated. Now, Herefort's is parotitis, uveitis, and fever that you see specifically with sarcoid. And that is on the Mix-Up 18 flashcards. So it is definitely showing up in the board review literature at this point as Herefort's. Yes. Yes, there are flashcards on them. We will be doing them at some point actually for GI. We'll do the GI flashcards. I'm going to make a game out of it somehow. All right, so treatment. Steroids, methotrexate, azathioprine, TNF-alpha inhibitors. Cardiac-wise, what do we worry about sarcoid? Heart block, right? So it's an infiltrative disorder. So it can actually infiltrate the myocardium in of itself, and it can cause a heart block associated with it. And I actually did have a case of this when I was like a newbie attending. This was like one of those humbling experiences sort of a thing. I was like newbie attending and I'm rounding on the weekend and this guy comes in with sarcoidosis and was just kind of feeling fatigued and a little short of breath. That was like his main complaint. And the team hands me over the EKG and I look at the EKG and the ER was so kind and wrote not STEMI on it and it's complete heart block. And so I was just like, so like about 3 other people had missed the complete heart block by the time that I'm rounding on it. And I was like, okay, this guy's in complete heart block and he's just chilling on 3H right now. And that was like my humbling experience because I'm like sounding the alarms and I'm freaking out. And the guy's just sitting there. He's chilling. Like his blood pressure's 120/80. He's totally fine. And I was like, transfer him to the CCU. And like Dr. Cohen's like just patting me on the back like, oh, you're adorable. He's like, we'll take him. That's fine. But you'll get his pacemaker. And like on Monday, he's totally fine. So that's one thing, right? Complete heart block. If they're asymptomatic, you could chill. Like they're fine. It's okay. That was something where I was just like, what? Huh? And they're like, yeah, in the VA, they'll schedule outpatient to get their actual pacemaker placed as long as they're stable. It's, oh yeah, they'll do it as an outpatient. But the other thing is too, is I'm slamming it with steroids, but the damage had been done. That's the other issue too, right? So yeah, sure, give them steroids, but you're not going to reverse that heart block. Like the damage has been done at that point, unfortunately. So that's why you really have to be conscientious and be watching them, right? So that they don't go into complete heart block. If you start noticing 1st degree heart block, oh, okay, we actually have to address this now before it develops into complete heart block. All right, sorry. That was like, again, those humbling experiences of when you have just enough knowledge, but not the full level of knowledge that you really need at that point. IgG4 related disease, this is also really starting to pick up a lot in the board review literature, in all honesty. So what do you guys know about IgG4 related disease besides autoimmune pancreatitis? What's that?
The orbital tumor that can kind of look like sarcoid.
So it's a really just bizarre disease in of itself. So, right, so you get the orbital pseudotumor that you can see with it. It's this weird infiltration fibrotic sort of disease. And so that's where they get the autoimmune pancreatitis. It's actually a fibrosis that you can see. You can get a thyroiditis associated with it too as well, which has got its own Riedel. That's what it is. It's Riedel, which I doubt we actually want to use because Riedel sounds German, so it's probably not a good thing. But either way, there's all these retroperitoneal fibrosis, actually, they're thinking is IgG4 related disease now too as well. So anything that causes like this unexplained fibrosis you really start thinking that this could be an IgG4 related disease, which is really quite interesting in of itself. So the IgG4 level is elevated. That's kind of our way of testing for it. And again, the thing that we just see more commonly is going to be the pancreatitis associated with it. That's when we go looking for it. But just keep in mind that this is a spectrum of diseases, right? So it's not just the pancreas that can be involved with IgG4 related disease. I think that that's the really important thing. And so if you start seeing a whole bunch of stuff being fibrotic and you don't have a reason for it, start thinking IgG4. And this again also showed up on the flashcards. So it is definitely seen more and more tested upon. So treatment is steroids, azathioprine, mycophenolate, methotrexate, and rituximab. So very good. Any questions? Let's see here. Alrighty. I'm like trying to figure out when is a good time to break here, but we're just running really quickly out of time. So let's talk about vasculitides, and then we'll take a quick 5-minute break after this, okay? Very quick. So vasculitides, a good way to kind of start breaking them down in your head is by the size of the vessel, all right? And so Dr. Aller kind of already did that with her fancy PowerPoint here. So you have your large vessel, your medium vessel, and your small vessel. The small vessel is what we see most commonly, in all honesty. I think that that's something that we see on a more regular basis, especially on the inpatient basis in general. Medium vessel to me is really they're very, very rare ones that we go searching for on occasion but don't typically find. And then large vessel, 1 out of the 2 is commonly seen. Not commonly, but at least on our differential quite frequently. All right, so large vessel is going to be your giant cell arteritis and your Takayatsus. Takayatsu, you will see, usually the patients come to you already diagnosed, unfortunately, but you will see it occasionally. Giant cell, definitely, 100%. Like we just had a case of somebody with a high suspicion of giant cell the last time I was on ward services. So definitely giant cell arteritis is something you need to consider. The big thing about giant cell arteritis is it's going to be in a patient older than 50. All right, so if they try to tell you they're like a 32-year-old and coming in with temporal lobe headaches, it is not giant cell arteritis and a 32-year-old with temporal lobe headaches, okay? So over 50, start thinking it, okay? Seen more commonly in females than in men. It's obviously a very large vessel because we're talking the arteries first off, so that's a large vessel in of itself, and it can actually affect the aorta in of itself. So one of the flashcards actually in Mixap this time is somebody talking about having arm claudication, and they're trying to get at subcranial giant cell arteritis. Okay, so it can affect all the major arteries branching off of the aorta, including the aorta. Okay, so keep that in mind. Other times that I've seen with the symptoms, because you guys already know, right? If they're coming in with temporal headaches and it's sensitive to the touch, yada yada, you're like, done, giant cell arteritis. So they usually try to get a smidge trickier, in all honesty, for the boards. That's a step 2 question, is, temporal lobe headaches, sensitive to the touch. So what they're going to maybe say is base of the tongue pain or neck pain, and still kind of maybe talk about claudication. So like after chewing, they just get tired and can't chew any longer. So that's really where they may say. So they might talk about kind of other anatomical sort of areas that could be affected versus just the temporal lobe, okay? They also have very low-grade systemic features associated with it too. So they may talk about like a mild weight loss, low-grade fevers that have been long-standing. So think about that too. What else is oftentimes seen with giant cell? What other rheumatological condition is associated with it? Polymyalgia rheumatica. So if they give you a history of polymyalgia rheumatica, and then they also tell you that they have like base of the tongue pain or neck pain, start thinking giant cell, okay? Because they're basically a spectrum of the vasculitis in of itself, okay? Our biggest concern, of course, is blindness. That's the thing that we'd never want to miss in these patients is blindness. So that's why we try to treat as quickly as possible. The SED rate should be very elevated. This is one of those few, like it's greater than 50. They may tell you 60, 70, but in real life too, if you ever have a SED rate greater than 100, have this in the back of your head as part of your differential, as that could be causing it, would be giant cell arteritis. Definitive treatment, of course, is going to be a temporal artery biopsy. Even if they don't have symptoms on the one side and the one side is negative, you go for the other side, basically. It's best to do it with some sort of imaging involved too as well. So there is ultrasound guided to look to see where the area of inflammation is the worst, or even doing an MRI beforehand. It will help the surgeons identify the area that they're going to get the best sampling, because you can get false negatives, right? So that's the sampling area there. So treatment, you guys know this, right? So you do high dose prednisone, so mg per kg. How long do you have before you can get the biopsy, before it'll start messing with the results? 2 weeks, right? So you could start them, if you have an index of suspicion, start them on the high dose steroids right out of the gate. If they already have ocular involvement, then usually you need even higher doses of steroids in those patients. But you have 2 weeks before you get the biopsy, before it's going to muck around with the results. So you have time. So you have time to do it, just go for it. Low dose aspirin is also associated with the treatment for it too as well. That's also showing up in the flashcards too. So you may need suppressive therapy long term. The good thing about this actually is that it is in the end self-limiting. So typically it'll last for like a year or two, and then just kind of goes into remission. People can do well afterwards. All right, that's good old giant cell. So remember the basic vague, also, fevers and weight loss, things along those lines associated with it. Because that's also going to help you with PMR too as well. It's like those other kind of low-grade systemic symptoms, because there's no antibodies associated with this. Takayatsu, so this one's pretty rare. Females is most common. Of course, you also think Asian population too as well, but it doesn't have to be. So very large vessel, aorta, again, and all of the branching vessels coming off of the aorta is what you see associated with it. So here you're going to have your systemic symptoms yet again. And with all your vasculitides, you typically will have those low-grade systemic symptoms. So fever, malaise. The big thing here, you could see decreased pulses associated with them. They can have breweries in very odd areas that you wouldn't necessarily expect to see. You could have changes in blood pressure between the extremities too as well. Depending if it's actually developed in the renal artery area, you can actually see hypertension in a very young patient. This is different though than fibromuscular dysplasia, so do keep that in mind. This is different. You can get aortic insufficiency, strokes, TIA, and syncope. So the big thing about this is when you actually see the angiography, these are very smooth narrowings of the vessels. This isn't like when we look at the cardiac caths on Fridays during our CCU, where you see that sausage-like sort of imaging, when you see like those constant like other narrowings. These are smooth areas, very, very smooth areas. And it's difficult, right? Because oftentimes really you're going to give steroids anytime that there's signs of inflammation. So they have active inflammation going on, that's when you're actually going to go ahead and do that. So it may just be the SED rates and things like that you're going to be looking for. It's very difficult to see when you're actually going to give steroids to these patients. Angioplasty is oftentimes not even that great, because it's not like this is coronary artery disease that they're trying to like smoosh away essentially, right? This is like actual stenotic type of lesions in of itself from inflammation. So angioplasty is very plus or minus in those regards. Alrighty. Any questions about Takayatsu? Pretty rare. So young patient though with really bad hypertension and weird breweries and maybe like missing pulses. It's usually the pulseless. That's kind of the classic stem. Then you're going to start thinking Takayatsu. All right. Now going into the medium vessel vasculitides. So the one that in the adult world we consider more frequently than any of these other ones, of course, is PAN, although still in of itself is extraordinarily rare. So polyarteritis nodosum, but I think fairly heavily tested on when it comes to vasculitides. This is your classic medium vessel vasculitis in of itself, and it has, of course, a very high association with hepatitis B. And that was actually one of the flashcards that I was seeing too as well, is that they kind of give you, the symptomatology of PAN, and it's what are you going to check next, and it's, of course, your hepatitis panel, right? So that's what you're going to be looking for to see if they have active Hep B, because this is one of those rare cases that if they're coming in with real bad polyarteritis nodosum, then they have active Hep B is where you would initiate treatment for Hep B, right? Because normally, right, we like write it out with Hep B. You're just like, you got it, fingers crossed, you're likely going to clear it, you're not going to need treatment. But if they have PAN in association with it, you have to treat the Hep B in association with the PAN. Okay. So more common in men than in women, see it commonly in middle age. It affects the kidneys, The GI, so they oftentimes will complain of abdominal pain associated with it because, right, you can get the mesenteric involvement seen on angiography. Specifically, peripheral nervous system, they get a mononeuritis multiplex oftentimes seen. You can get skin, testicular involvement, ovarian involvement, coronaries, yet of course. So the symptoms: fever, malaise, myalgias, mesenteric ischemia. Livido reticularis is the common rash that they often talk to you about. So you guys know that kind of dependent, lacy sort of looking purplish rash that you'd see with livido reticularis. Hypertension if the renal arteries are involved. Orchitis is really the testicular involvement that you would see. And it spares the lung, which I think you guys all know that, right? Because when we think about our vasculitides affecting the kidneys, this is not the one that also affects the lungs, right? Because when we get into our small vessels, all of them are kind of your pulmonary renal sort of syndromes in of itself. But this one, no lung involvement with PAN. Also, no antibody to test for in PAN, other than hepatitis. But that's, you know what I mean? Like there's not an actual rheumatological antibody to go for it. So the diagnosis, it'll be a clinical picture, everything kind of coming together in of itself. You would expect to see active sediment on the urinalysis if there is renal involvement in of itself. And then you really need to do an angiogram of some sorts, whether it's a CT angio of the abdomen or an actual straight up angiogram that you're going to ask IR to go ahead and do, because you're going to be really looking at the mesenteric involvement or the renal involvement, and you're looking for aneurysms and things along those lines associated with it, okay? So the treatment is very aggressive. You have to do high-dose prednisone and Cytoxan. If they have Hep B, go ahead and start treating with antivirals, and sometimes you even have to do plasma exchange in those patients as well, okay? So just Hep B, Hep B, Hep B, like really like trying to hammer that in for PAN. Specifically, think abdomen, kidneys, no lungs. All right, and then mononeuritis multiplex, like that's also very commonly seen too as well with it. So Kawasaki, my med-peds people, do you want to tell us about Kawasaki? Because we don't really see this as an adult. So, what was that? Crash and burn, okay.
So crash is your mnemonic for when something virus burn is your fever.
Oh, okay. Alrighty. So, I mean, like you get the strawberry tongue, right?
Yeah.
Okay, you get a conjunctivitis of some sort, right?
C for conjunctivitis, R for rash, which can be maculopapular
Like
or the
literally
hand.
any rash. Any rash.
Any rash,
Any
okay.
rash.
Any rash.
Arthralgia, your S's, you just said.
Strawberry tongue.
Strawberry tongue, thank you, yeah, and H?
You did desquamation.
And like, right, you get desquamation of the hands too, right? Okay.
When they peel.
Yes. So desquamation of the hands. So you
It's
all,
like a cervical adenopathy, but it has to be unilateral cervical adenopathy.
unilateral cervical adenopathy. Okay, that was not one that I associate off the top of my head with Kawasaki's. For me, I keep it pretty limited, right? So I think if I see desquamating hands, I see a strawberry tongue, a conjunctivitis, and a young patient as well, then I'm going to start thinking, and fevers as well. I'm thinking, okay, this is going to be potentially Kawasaki's.
5+ days of very high fever.
Very high fever, right, exactly. So 5+ days, this isn't like your classic, because I guess like scarlet fever is probably your one thing that could really kind of, some people may start thinking, you know, is this Kawasaki's? No, it's just actually scarlet fever, right? So 5+ days of very high fever, start thinking Kawasaki disease. Coronary artery aneurysms, you guys know this from medical school. This is your classic medical school type question. That's the thing that we get worried about. This is the one time we give aspirin to children, although I wonder if they're going to research that a bit more, because I feel like the aspirin thing's overblown when it comes to the varicella zoster, you know,
They're doing
type
less
things.
high dose now in a lot of countries, so.
Oh, okay. So anyway, this is the one time give aspirin to your patients that are pediatric in general, and it's to help to actually decrease the chance for the coronary artery aneurysms. They need long-term follow-up with echocardiograms, stress tests, and EKGs because of those coronary aneurysms in of itself. All right, Kawasaki's. Now, primary angioitis of the CNS, this is obviously not very common. You can see it, again, older patients, 50+, affects intracerebral areas only. The symptoms is recurrent headache, progressive encephalopathy. You diagnose normal sed rate in this, so you could do an LP. The CSF, you're going to have more lymphocytes and high protein. The definitive diagnosis is going to be a brain biopsy, which obviously does not happen very frequently in of itself, and you're going to see necrotizing granulomas, and then it's high-dose steroids and Cytoxan. That's going to be seen with that, which I think for the most part we would probably start a lot of people on high-dose steroids in these cases regardless. All right, now going into small vessel, which again I think is something that we work up at the very least fairly frequently, even if we don't necessarily see it fairly frequently. So you have to think of your ANCA-associated vasculitides and your immune complex-associated vasculitides in of itself. So starting off with our ANCA, we have 3. And we're getting away from all of our eponyms, so now they have really, really long names instead that also sound very similar to one another. So Wegener's, we're no longer calling it Wegener's. It is now GPA, granulomatosis with polyangiitis. So that's GPA in of itself. Which antibody is associated with Wegener's? C-ANCA. Okay, very good. You got to know the antibodies, right? Always know the antibodies. You have microscopic polyangiitis, which has always just really been microscopic polyangiitis. Which antibody is associated with it? P-ANCA. P-ANCA. And then you had what used to be known as Shirk-Strauss, but now we are calling it eosinophilic granulomatosis with polyangiitis. Right. Which antibody is associated with it? P-ANCA, right? So P-ANCA again there. All right, so going back to our Wegener's. The Wegener's, they really like to focus a lot on the upper respiratory tract involvement because that's what also kind of makes us stand out even a bit more. So like recurrent sinusitis, recurrent ear infections, like in an adult, which is rare, right? We don't see a lot of recurrent ear infections with adults. Also lung involvement and kidney involvement. You start thinking this is Wegener's, okay? This is going to be your granulomatosis with polyangiitis if you have those constellation of symptoms. It can be erosive, so that's why they get the saddle nose in of itself. You can have nondescript pulmonary infiltrates that could even lead up to DAH in of itself. Rashes otherwise, they can develop a palpable purpura, which you could see with almost any small vessel vasculitis, in all honesty, is that palpable purpura. You can get ulcerative skin lesions as well, and of course the glomerulonephritis is a really big hallmark thing that we typically see for this. So you guys know C-ANCA is a big thing. If you had to choose an organ to biopsy, go lung over kidneys. Sometimes you have to do both to get your diagnosis, in all honesty. So treatment, though, the good thing is when it comes to microscopic polyangiitis and Wegener's, the treatment's going to be the same. So even if on the boards you're waffling between the two, but they may ask for treatment, so it doesn't matter. The treatment will be the same either way. So high-dose steroids, Cytoxan, rituximab. There's plenty of literature that with any ANCA-associated vasculitis that may not even fall into these 2 categories because sometimes that doesn't fit perfectly, and so it just may be generic ANCA-associated vasculitis. Rituximab plus Cytoxan is really showing major benefits in these patients, especially when it comes to relapses. So you can do maintenance therapy with methotrexate, azathioprine, and mofetil. Microscopic polyangiitis, you don't really have that upper respiratory tract involvement associated with it, but you still get the kidney, lung, and skin P-ANCA associated treatment the same. The eosinophilic granulomatosis, the good thing is about Shirk-Strauss is it tends to not be as awful as these other 2. So it's usually a bit better prognosis in general, and you oftentimes don't need to go as far as using cyclophosphamide in it because it's pretty rare to have very severe disease associated with it. And then, of course, eosinophils is a huge thing. Clearly, it's in the name, so that's the other thing that's going to stand out in regards to this vasculitis is the eosinophil portion of it. So it has lung involvement. It can have a peripheral nervous system. So again, think your mononeuritis multiplex. Very rarely are the kidneys actually involved with this one, but it can be. So think more lower respiratory tract infection, high IgE, high EOs in the biopsy, and they may not have any negative. So up to 40% of them actually may not have an ANCA association with it. So it could actually not be that common. But think of it not quite as severe of disease. So steroids oftentimes is good enough. Don't necessarily have to do the Cytoxan, don't necessarily need the rituximab associated with this one. All right, any questions about the ANCA-associated vasculitides? No? Okay, good. All right, immune complex vasculitis. So cryoglobulinemia. What do you guys know about cryoglobulinemia? Hep C, right? The Hep C, like that's going to be like the most important thing. It's just don't confuse your Hep B and your Hep C, right? So Hep B, PAN, Hep C, cryoglobulinemia, okay? So that's like the big thing that you're associated. Now there are different types of cryoglobulinemia. I don't think that they will ask you that on the test. I think that that's getting way too deep involved, in all honesty. But you remember purpura, right? So they oftentimes, especially in the lower extremities, will have a palpable purpura associated with it. You're going to have a low complement level. This is one of those ones, like Dr. Aller's been really talking a lot lately in Morning Report about what causes low complement levels, cryoglobulinemia. You're going to have obviously positive cryoglobulins too as well. So the treatment is you want to treat the underlying hep C if you see that associated steroids, Cytoxan. If they have end organ damage and are severely sick, that's when you start doing plasma exchange and rituximab. Okay. So yes, I think the classic thing is an acute kidney failure, somebody with hep C, and that palpable purpura rash is when you're going to start thinking cryoglobulinemia in this patient. Okay. HSP also have palpable purpura. Right? This is your guys' domain, but I've seen this in adults. So this one I've seen in adults. I've diagnosed HSP before. Never diagnosed Kawasaki's. Probably never going to.
Come to
But-
peds, we see it like once a week.
Oh, yeah. But I will never see personally Kawasaki's. But HSP we do see. So what do you guys think about with HSP? Yes. Yes, exactly. So abdominal pain, joint pain, lower extremity, palpable purpura type rash, recent URI, right? So that's what we think about with HSP. What is the actual vascular, like the immune complex? IgA. Good. So it's IgA mediated immune complex. That's what you're going to see on biopsy, right? So when you're going to biopsy it. So the urinalysis is obviously also going to be active sediment. It's going to be positive in of itself. So it's really steroids, but it's oftentimes self-limiting in of itself. So good. HSP, classics. Abdominal pain, joint pain, renal involvement, and palpable purpura, think HSP. That's my adult version of it. Okay. Hypersensitivity vasculitis. So this can happen with exposure to various drugs versus infection, and it affects the skin. It's your classic leukocytoclastic vasculitis, which is again your palpable purpura. You can do a biopsy. Just remove the offending agent. If you need to, you can do steroids if it's severe, or you can also do colchicine, dapsone, and NSAIDs. So that one, again, think about time frame to a drug exposure. And now they've developed a leukocytoclastic vasculitis type of a picture. Okay. So anything with drug associated. Any questions? All right, let's take a 5-minute break. Really, truly 5 minutes.
I'll take her. Okay.
Yeah, I know. He's like, oh, it's not like 14. I'll take a look at it. Yeah, I mean, I'll look at it tonight. All the other ones, we can start practicing now. Seven to 8 songs.
That was the problem. I'm pretty sure I'm gonna change my parents. Yeah, but I'll be up 10 pounds.
Oh, they're so good.
Well, the problem was, my last one was after I changed, so I can like drop 10 pounds on my week. So I was like back at my baseline. So I'm even, I got lost weight. I should be down more though. Just not gonna go. I'm really beat out. I see her come out from the cafeteria, so I gotta watch where I go. I've been doing good at making salad. I need to start working out from eating. Hey, Earl. Good morning.
This is like the most I've been able to do, like 2 seasons. And then I'm going to my honeymoon. You know what? It's going to get another one.
I need to like figure out whenever I get the test. My mom, this is how like I'm just like not scared. She has a personal shopper. She's with the tax her lady pulled her stuff for her. I'm like, why am I shopping for you when you have a personal shopper? She offered to buy me an outfit, but I was like so not in the spirit. I was just like, I'll wear something like that. That's like how you do. I'm just like down trying. No, this is the like this is yeah, it's the same. We got an intern year, just like y'all. Flowers around here. It makes it easier. No, it does. I won't say that. Did you all? I'm like, so I'm like sad I gotta work that ER. I wish I had enough money to put that shit.
How much money does it take to give you
I don't, probably at least 250.
like what? Yeah, does anyone want to make like
I ain't gonna lie, that could be something. Wait, my mom did offer to buy me outfits.
Hey guys, quick question. I have an ER overflow shift coming up on October 8th, and I'm willing to, March 8th. I am willing to sell it to someone for $150.
$300.
It's starting at $150.
two for 300? Mine on May. Buy one get one free.
Any takers? No takers?
Buy one get one free.
What are you guys selling over here? Alrighty. All right. I just realized that that's been recording this whole entire time.
It goes out to the audience as well.
So I don't know what you guys all said, but the future generations are going to hear it for years.
Spell my ER overflow here.
Alrighty, we have very little time here, so let's get right back into this. Oh no, it's fine. All right, so let's talk about our myopathies. Hooray, myopathies. I know, I saw Dr. My sitting back there. I know. My heart rate went up a little bit. All righty. So our myopathies. You guys know dermatomyositis. I think you guys know polymyositis. You probably don't know inclusion body myositis all that well. So we'll talk about inclusion body myositis kind of on its own, separate type deal. So dermatomyositis. There's some very hallmark features of dermatomyositis. Why don't you guys tell me those? What are Gottron's papules?
That picture.
Yes, right here. So that lovely picture. I'm not gonna, because it'll cover it up if I move the mouse. So right. So when you have it like on your MCP, your pips and your dips, this kind of like thickish sort of rash that you would see there, that's your Gottron's papules. What else?
The
Shawl sign. Very good. So, what's that? Interstitial lung disease. But let's talk about the skin findings still first. Hold on. We're not done with the skin. The heliotropic rash, right? So your periorbital kind of purplish discoloration around there, all very common, pathognomonic for dermatomyositis. So the shawl sign too, remember you can get photosensitivity rash, and it's both front of the chest, back too as well. There's the holster sign too that you can see associated with it. So it's kind of on the lateral portion of the hips, like where you would have a gun holster, so to speak, that you can also see. So good. Those are your classic sort of rashes that you're going to see with it. So keep in mind though that the mechanism between dermatomyositis and polymyositis are different. Okay, so even though there's some similarities in regards to presentations, the biopsies are actually very different. So the biopsies are really going to help you decide, because you can have dermatomyositis without any rash, right? So you can have that. Just keep in mind that biopsies will be the same, but just no rash associated with it. But they're different from that of polymyositis, okay? So the mechanism of dermatomyositis is immune complex, causing vascular inflammation, whereas polymyositis is going to be T-cell mediated direct myocyte injury, okay? So keep that in mind. The actual muscular manifestations for the two of them are same, right? So it's proximal muscle weakness that we see associated with it. So that's where you ask them, like, do you have difficulty getting up out of a chair? You know, those are the questions that you're going to see, and that's really what you're going to be testing on in your physical exam. If it's an upper extremity, about like asking if they can brush their hair, if they have difficulty doing that, climbing upstairs, etc. All right, so with dermatomyositis, it could be seen in younger patients. If it's seen with an older patient, which we, not too long ago, somebody had an older patient who was like 90. I think we actually got them from MedCon, actually. We transferred them over to the internal medicine service, and it was perineoplastic, right? So if you see somebody with classic dermatomyositis or a polymyositis even, and they're like 90, think this is a perineoplastic-driven process and try to find their cancer, potentially. But we'll talk about cancer screening in a second. Okay, so polymyositis is typically in the 40s. The extramuscular manifestations that you can see with both of these entities, your fever, you can see Raynaud's, you can see an arthritis, lung disease. We already talked about, Phil had mentioned, interstitial lung disease is a very common feature that is associated with that in general. You get chest diaphragm weakness, esophageal disease, you can get dysphagia and aspiration pneumonia. That's going to be for more of the skeletal muscle portion of dysphagia, right? Not necessarily the smooth muscle portion of the esophagus. So more the oropharyngeal phase is what you could see being affected in regards to the dysphagia. Okay, so we talked about the rashes already. Polymyositis is kind of like a subset of an anti-synthetase syndrome, which is seen with anti-Jo positive, which is also anti-tRNA synthetase. So it's like a much longer word, but it's also known as anti-Jo. That's where you can see the mechanic hands specifically associated with it. So that's like basically where they have hyperkeratosis of their hands. You can kind of, the picture here is not that great because it's kind of small, but it's kind of like where you can see sort of a like really dry sort of cracking of the skin at the fingertips, and they call it mechanic's hands because it looks like a mechanic, right, who's really rough on their hands. Sometimes it always has like a dirty appearance. They might say like, I wash my hands constantly, they always seem dirty to me. That would be sort of your kind of classic mechanic's hands description. So for both of these, your CPK is going to be fairly elevated. That's going to be your number one test. Aldolase is kind of like old school testing. That's not going to be that specific for it. And then you can have ANA being positive and up to 80% for both dermato and polymyositis. Now, specific antibodies associated with them, dermatomyositis, you can think about MI2 as being more commonly associated with dermatomyositis. Polymyositis, we talked about the anti-Jo, which again is going to be more so related to like your anti-synthetase syndrome, but also anti-Jo does increase your risk for having interstitial lung disease, okay? So when you have that positive antibody, they're having even more risk for interstitial lung disease seen with it. And then there's also SRP, which is signal recognition particle. So how do we diagnose it? So an MRI is oftentimes very helpful to show the areas of inflammation. So that'll help guide the surgeons of getting a good sample for a muscle biopsy. And then you also can do an EMG looking for myopathic changes specifically with it too as well. All right, so on the biopsy, as I already told you, it's going to be different between the dermato and the poly since the mechanism of action behind it is going to be different. So muscle biopsy and that of dermato is going to have a B/T cell perivascular infiltrate with an actual vasculitis with microinfarction and grouping fibers. So vasculitis, kind of think that with the dermato. Polymyositis is going to be more T cell mediated, as we already discussed. So CD8 T cell, it's going to involve all muscle layers, and you're going to see myophagocytosis. Okay. Treatment. Start off with some high-dose steroids, plus or minus a steroid-sparing agent such as azathioprine, methotrexate. We see IVG used quite frequently, especially on the medicine consult service. We'll get patients who are underneath like the neurology service that will consult us for like their diabetes management or something along those lines, and they're just here to get their IVIG. So they get routine IVIG treatment. So the malignancy workup, you're going to see the real world doing a whole bunch of crazy stuff, like pan scanning patients and things along those lines. That is not what they're looking for on the exam. They want you to do age-appropriate cancer screening. All right. Now, if they have symptomatology to suggest something else, so if they're a female, right, we don't have age-appropriate ovarian cancer screening, and that's the type of cancer that's most commonly associated in females in dermatomyositis, is ovarian cancer. But if they have like talked to you about bloating or abdominal distension, then you can go searching for the ovarian cancer, okay? All right, but keep in mind, age-appropriate cancer screening. Like that's gonna be the correct answer on the test. But you'll see here in real life that rheumatology is pan scanning everybody. Okay, and it is more commonly seen with dermatomyositis than that of polymyositis association malignancies, but again, you're gonna see it in real life, both of them. All righty. So other manifestations is there is an amyopathic dermatomyositis, so you can have the rash, but no muscle involvements. Their CPK will be normal. They're not going to have any muscular weaknesses or anything like that. You basically treat as if it was straight up normal dermatomyositis. You also still have that risk for cancer involvement associated with it. We kind of already mentioned the anti-synthetase syndrome. So you have the mechanics hands, interstitial lung disease, Raynaud's. They're obviously going to be Jo1 positive. Those patients have a poorer prognosis. Okay, they're less responsive to treatment. Yeah.
Why do they call it amyopathic dermatomyositis? Like, why have the myositis part in there at all?
I don't know. Yeah, I think it's just because it's such the classic rash that you would see with dermatomyositis that they want you to still connect it, that you can be amyopathic though. So, yeah, interesting. And then you can also, like I said, you can have their myositis without the rash as well, or any of the skin findings. But the biopsy will tell you, like, this isn't dermatomyositis. And the reason why that's important, again, is the dermatomyositis has a higher incidence for the perineoplastic processes. So that's why it's good to be able to differentiate between the two, because really the treatments are the same, essentially. And also you do want to do screening for interstitial lung disease on these patients. So if you make the diagnosis, oftentimes we would do high-res CT scans too, right, to look at the baseline of the actual lungs too on these patients, especially if they're Jo1 positive, so especially. So other associated antibodies that can be seen, Rho, La, U1RNP, especially with the mixed connective tissue disorder. Remember we talked about that earlier. PMSCL, COO, which is seen in a scleroderma myositis type overlap. So if it's just systemic sclerosis and myositis without the lupus features, that's its own overlap, and you can see this anti-COO. I've never yet to see any questions on asking for anti-COO, so I think that that's a little bit esoteric in all honesty. But those are kind of the big deals with dermato and poly. So think about your interstitial lung disease, especially with anti-Jo1 positivity. Think about your cancer screening, age appropriate in of itself. You guys know the rash is great. I don't have to explain those to you any longer. Proximal muscle weakness, that's the big deal. So now inclusion body myositis is really quite different in comparison to the other two in general, okay? First off, you're gonna see it in a much older patient population. This is much more insidious in nature, so it's oftentimes diagnosed pretty late in the disease course in of itself. And the huge hallmark difference between this is that it's proximal and distal muscle weakness, okay? So if you're starting thinking that this could be a myositis and they start talking about distal muscle weakness, you're thinking inclusion body myositis, okay? So oftentimes they'll talk about like a patient keeps dropping something, or they notice that their handshake is very weak in grip. So those are kind of the illness scripts that they oftentimes will write, okay? The mechanism is vacuolar inclusions. It's a myodegenerative type of disease. So extramuscular manifestations are pretty rare. You may have some esophageal dysfunction. Workup, the CPK, you're going to have elevated CPKs, but nowhere near to the level of the other myositis. Again, this is more insidious in onset, okay? So you're not going to have this huge elevation of the CPK. SED rate is going to be normal. There's no autoantibodies. This is going to be biopsy or EMG proven, okay? So in the EMG, it's going to show it's myoneuropathic. The muscle biopsy is going to be mild T-cell inflammation with rim vacuoles and fiber inclusions. So they're going to be nice and likely use the word inclusion somewhere in the description of the pathology. So that will be helpful. Treatment here is going to be high-dose steroids, but in all honesty, they have a very poor response in general because oftentimes, again, you have caught it way late in the game. All right. Any questions about inclusion body? So remember distal muscle involvement. Okay. So pictures here, you guys have your Gauchard's papules, you have your heliotropic rash, you also have the mechanic's hands there. So other things that sometimes can be a little bit confusing, we have a couple of little scenarios here. So patient on steroids for polymyositis, CPK and sed rate are now normal. However, there's weakness. The weakness that initially started improving, now it's worsening. So what's happening here? Steroid-induced myopathy. Excellent. Good. Patient with a history of gout on therapy presents with weakness. The CPK is elevated. Muscle biopsy shows vacuoles without inflammation. So the gout here is the key, right? So they're telling you this is a patient with gout who is on therapy. So what gout therapy can cause a myopathy? Colchicine. Yeah, so this is a colchicine-induced myopathy. Good. Patient diagnosed with coronary artery disease 3 months ago is on a beta blocker statin and ACE inhibitor, now has muscle pain, CPK is elevated, EMG is normal. Statin-induced. Excellent. Good. Patient with myalgias after exercise, proximal muscle weakness, delayed relaxation, deep tendon reflexes, thinning of the lateral eyebrows, CPK is elevated, EMG is likely to be normal. Hypothyroidism. And this was like I had a case of this actually, where a patient was sent in by their primary care doctor because they thought they had polymyositis. Their CPK was in the 2000s. They had been on a statin. They stopped the statin. I think they switched it, still had elevated, stopped the statins, sent him in. This guy now is so weak he can't even get out of bed. And my team already had the surgery lined up. He was getting his biopsy the next morning. I was like, time out. What's the TSH on this guy? Nobody had checked it, including the family medicine doctor, and it was 250. So, yeah. Thankfully not in mixed edema coma. So it was pretty impressive. So I was like, how about we give him some Synthroid, and then we'll see what happens. So he did not get a biopsy. All right. Patient with no past medical history presents with acute fevers, pain, swelling, warmth in the upper arm. No, I mean, that's just acute, right? So this is acute. This is an infection, right? So just remember, you can actually get an actual infectious pyomyositis. Fatigable muscle weakness that improves with rest. Other symptoms include ptosis and nasallar speech. Myasthenia, very good. Proximal muscle weakness, bone pain, pseudofractures on x-ray, labs with low calcium. Uh-huh. Excellent, very good. Alrighty. This is where my interest starts going down with rheumatology because this is becoming more outpatient. So I love all the other workups. Now I'm kind of ugh. And we only have 4 minutes. So unfortunately the musculoskeletal pain here. So I'm going to really run through the crystal arthropathies because they really like to test on this. And then the OA. And at some point when you guys have a break today, I can go over the muscular stuff, and then we also do have some questions, but we're unfortunately out of time. So we'll figure out when I can sneak into the rest. All right, so in regards to gout, gout goes back to med school days, right? So there's going to be certain features of gout that you tell me about gout. And you guys treat gout more than I do. So you guys teach me about gout. Podagra, okay, that's the classic, right? So your first metatarsal joint is your classic podagra that you can see with gout. All right, well tell me though, what are risk factors for gout? Male, right? So you don't typically see gout in premenopausal women. So it's going to be postmenopausal women. Alcohol, red meat, right? Anything with high purine levels, anything that causes increased cellular turnover, so polycythemia vera, leukemia, hemolytic anemias, things like that. That's going to also increase your risk for gout. The symptoms, it can cause fever. It's usually going to be a monoarticular, but it can be illegal, even polyarticular in very unfortunate people. But generally it's a monoarticular arthropathy. Red, very warm, very, very, very painful. It can mimic that of cellulitis or even a joint infection in of itself. So, it's something that you always have to be concerned about. So the podagra, you guys already know about. It can also cause bursitis. Olecranon is probably the most common, right, where you can see that here in the elbow. Frequent flares can lead to chronic tophaceous gouty formation, and that actually alters how you treat those patients specifically. So your workup, you may have a little bit of a leukocytosis. Your sed rate is going to be elevated. Your serum uric acid level, remember, is not diagnostic. So it doesn't have to be high. It could be normal, and you could still have gout. So really, of course, the best thing to do is always aspirate the joint and try to actually look at the fluid, and you're looking for the crystals, and you should know how to describe the crystals of gout in of itself. So negative birefringence, needle-shaped, which makes sense why it's so dang painful, and it's intracellular during acute attacks. The synovial white blood cell is going to be in the inflammatory range, so it could really be anything above 2,000, right? And that's something where they love to ask you about, is that if it's going to be somebody you're going to tap their joint and their white blood cell count is 60, let's say 90,000, and it's 90% PMNs, and they do see crystals, still treat for septic arthritis. Okay, just because there's crystals doesn't mean it's just gout. You're still concerned for septic arthritis. Okay, so still give antibiotics in those patients. X-ray findings is the other thing that they love to talk about. So it's going to be punched out lesions. Oftentimes you're going to hear that description as punched out lesions with an overhanging edge. I think they used to even call it like a rat bite. Like the way that it would actually look would be like a rat bite. So that's your kind of classic gout sort of feature there in of itself. The treatment in an acute flare, colchicine, NSAIDs, and steroids are kind of your three mainstays for acute treatment. We obviously all know you don't initiate allopurinol in an acute flare because it can worsen the flare in of itself. Chronic versus prophy. So when do you actually give somebody prophylactic treatment with allopurinol? So somebody who's had 2+ attacks in a year, or if they have chronic kidney disease or tophi, those are the patients that you want to actually start on allopurinol. You advise them to be on a low purine diet, weight loss. You of course want to avoid your hydrochlorothiazide, niacin. So you treat for a goal of a uric acid of less than 6. Your xanthine oxidase inhibitors are kind of our mainstays in those, so allopurinol, febuxostat. Allopurinol, of course, has a lot of drug-to-drug interactions that you need to be aware of, and of course, you can also develop other issues with allopurinol, so like DRESS syndrome and things like that you sometimes can see with allopurinol. So if they've had some sort of hypersensitivity reaction to allopurinol, febuxostat is going to be your best friend in those regards for a xanthine oxidase inhibitor. The uricosuric, I've never see used, so probenecid is something you learn about in real life practice. You never see it, but just don't do it in a patient who's had a history of uric acid stones. That sounds like a bad idea. And then also if they have chronic kidney disease with a creatinine of greater than 2, you don't want to do that either. There is IV synthetic uricase, so this is like rasburicase essentially. We have pegloticase for severe refractory attacks. You can actually give that as well. Don't start chronic therapy, obviously, during an attack. Give flare prophy for up to 6 months when starting chronic therapy, typically daily or BID colchicine. So you want to, while initiating allopurinol, give them prophy for a potential acute flare too as well. Alrighty, classic things for gout. The big one with allopurinol in regards to dose reduction is going to be your methotrexate and azathioprine. 6-MP and azathioprine, you have to significantly reduce their dosing because of the drug-to-drug interaction. It can cause major bone marrow suppression otherwise. Okay, so you significantly have to reduce those doses if you're going to use allopurinol. All right, pseudogout or calcium pyrophosphate deposition. So quite different from that of gout, although treatment a little bit the same. Just no xanthine oxidase, obviously, because it has nothing to do with uric acid. So risk factors, if they've had a prior injury to a joint, if it runs in the family, age, and a person who's less than 50, you have to start thinking of other systemic causes of pseudogout. So hemochromatosis, hyperparathyroidism, hypothyroidism, and hypomagnesemia can all lead to pseudogout, or CPPD is what we call it in of itself. So really, particularly hemochromatosis and hyperparathyroid. Like always have that in the back of your head as being systemic causes of leading to CPPD. So symptoms, again, same, very acute pain, erythema, warmth. The joints are going to be a little bit different here. So these are going to be more of the larger joints. So like if you think of your knee, your wrist, your shoulder, not kind of your classic podagra that you would see typically with gout, although gout can be anywhere too as well. So chronic CPP, crystal inflammatory arthritis, is another thing that you can sometimes see. It can look like rheumatoid arthritis. It's known as pseudo-RA. So workup, you can see the chondrocalcinosis on the X-ray. So you see like a hyperintensity linear kind of white finding on the actual X-rays that you'll see with pseudogout specifically. The synovial fluid again will be in the inflammatory range. The crystals here are positive, not negative, so positive birefringent, and they're rhomboid shaped. So it's not quite as painful of that of gout as well. So the treatment, acutely, NSAID, steroids, and colchicine are going to be your options. Prophylaxis is if they've had more than 3 attacks in the year. Then you could do low-dose colchicine or NSAIDs. For pseudo-RA, you can do low-dose steroids, methotrexate, or hydroxychloroquine in of itself. So the stuff that I typically, again, see commonly in the mix app is hemochromatosis, hyperparathyroidism, and then, of course, the X-ray findings are sort of the classic things that I see tested upon them, CPPD. So basic calcium phosphate deposition, aka hydroxyapatite this has showed up in every single mix-up question bank I've ever seen. This is your Milwaukee shoulder, and it's usually a little old lady that has an extraordinarily erosive arthritis of the shoulder. Like the chest X-ray, the X-rays of the shoulders are impressive. So Google image this. It's impressive how it really just eats away completely the humeral head, basically. It's really quite impressive. So it's painful, swelling, very destructive. So when you actually tap it, it's not going to be inflammatory. So the white blood cell count is going to be less than 2,000. There's no crystals that are seen on polarized light. You have to do a special stain. And this is one of the questions they like to ask a lot, is the alizarin red stain specifically. Sometimes they are really just trying to get you to name it because it's, for whatever reason, it's not commonly recognized, I think, amongst everybody. But they may ask for the stain too as well. So the alizarin red stain specifically. Treatment is NSAIDs, joint lavage, steroid injections. Please do Google image it. It is impressive, okay? OA, you guys know OA. I don't think there's a ton to talk about here. So obviously it's a use, right? Repetitive use type of a thing that we typically see with osteoarthritis. So knee, hips, we see it very commonly here in the United States because people are overweight and the knees aren't meant to carry 400 pounds. So spine, hands, feet. If you see it in like the hands and the feet, it's often because it's occupational. So carpenters, things along those lines are going to more likely have hand arthritis. For the hands, you get the bony enlargements, the Heberdens, Bouchards. Remember those. So, distal is the Heberdens, proximal is the Bouchards. Joints, you get bony enlargement. You can get crepitus, stiffness with rest, but obviously we already talked about it. It doesn't last longer than 60 minutes. You can have effusions. It can be asymmetric. There is such a thing as erosive osteoarthritis, though, so do keep that in mind. It's oftentimes in the fingers. It causes central erosions in the X-rays, can have flares of redness and swelling. Secondary osteoarthritis can occur in settings of abnormal joints, so you can see OA in association with rheumatoid arthritis or avascular necrosis, gout, septic joints. So, secondary reasons that you've had issues with that joint in of itself. DISH is a interesting entity in of itself. So it stands for diffuse idiopathic skeletal hyperostosis. So they'll talk about flowing osteophytes spanning 4+ vertebra. It's typically right-sided as well. That's another interesting thing about it. But if you hear the term flowing osteophytes spanning more than 4 vertebral spaces in the spine, start thinking of DISH in these patients. More commonly seen in men, oftentimes with a history of diabetes. The treatment is really conservative, physical therapy, things along those lines. Workup for osteoarthritis, synovial fluid you can do if they have it, right? Because anytime you have a red swollen joint, the next thing you do is you tap it. So anytime that you see that on an exam, as long as there's not overlying cellulitis, you tap it. X-ray, joint space narrowing, osteophyte formation, so marginal osteophyte formation, subchondral sclerosis. So you're not going to see the periarticular osteopenia that we'd see with RA, right? So this is going to be subchondral sclerosis that you're going to see specifically with it. Osteophyte formation is very classic for OA. Other weird osteophyte formation, if you see MCP joint hook-like osteophyte formation, that's hemochromatosis. Treatment, you guys know the treatments. Weight loss, PT, try to be conservative as possible. Drug of choice here, Tylenol, no longer, so erase that. There's no benefit to Tylenol. They may ask you what's the benefit of Tylenol. That's actually in the MixApp 18 questions, and it says no benefit with Tylenol. All right, so you can use NSAIDs. Be cautious with the usage of NSAIDs in all of your patients. Oftentimes topical is going to be preferred, right? So you're not going to have the systemic side effects of NSAIDs. So if you can get away with topical NSAIDs, use topical NSAIDs, although they're expensive. Tramadol, duloxetine, very severe pain, you may have to use opiates. Okay, then of course it's also your muscle strengthening, weight loss is the big key things here. And then if everything fails, you refer for joint replacement, okay? For when everything else has failed, you can also short-term use the intra-articular injections of steroids. Remember, you can only do it every 3 months to avoid the systemic issues of steroids, okay? Fibromyalgia, you guys know it. Don't give narcotics. They're going to have a whole bunch of other interesting psychological complaints typically with it as well. So chronic fatigue, all those kind of fun stuff is going to be your fibromyalgia. No narcotics. Treatments, nothing for SSRIs. You can use SNRIs. Milnacipran is specifically for fibromyalgia. Lyrica also has been approved for fibromyalgia. TCAs could also be on here too as well. Yeah. So that is like a drug specifically approved, and I'm already blanking on the brand name of it. Sevella, that's it. Sevella, thank you. Sevella.
What like class of medication?
What is it exactly? Let me look it up for you. I always forget it.
Antidepressant, SNRI.
It's an SNRI, but it's one specifically for fibromyalgia though. Thank you. But nothing SSRIs. That was also on the flashcards for MixUp 18. There's benefit of SSRIs and fibromyalgia. No, you don't use SSRIs. SNRIs. Alrighty, and I'm unfortunately out of time. But there's these wonderful questions here that are the worst, but they really like to test on. So we can go over this at some point that you guys have another break in the schedule. I can come back and kind of discuss this. And there are some questions too as well. Okay? But I'm going to sign out here and